It blocks the effects of benzos. It is approved for use in reversing the CNS depressive effects of benzo overdose and helps to hasten the recovery following the use of these drugs in certain procedures. So benzos are considered much safer than barbiturates when taken alone and orally. I don't have a slide about barbiturates because they're not really used as much anymore, but do want to make a couple notes that the barbiturates are a class that fall under the category of sedative hypnotics. The barbiturates are rarely used anymore due to their high potential for abuse and overdose and lack of antidote to reverse the effects. They're still used for some things such as anesthesia, rarely epilepsy, but they're not routinely prescribed for anxiety disorder anymore. Barbiturates, depressant effects are dose dependent. Some of the barbiturates can have a half-life of up to 100 hours. Biggest issue when using barbiturates, they're powerful inducers of liver enzymes. And they just have, a lot of potential side effects, especially respiratory depression. And flumazenil can't be used in barbiturate overdose. So there's no antidote. Okay, so let's talk about migraine treatment. Just a kind of classic case example. The leak book has the leak review book has a lot of classic cases. I like it when you're studying for boards. But this is like an adult woman that complains of gradual onset of a throbbing headache behind one eye that gradually worsens over several hours. They may complain of sensitivity to bright light, photophobia, or sensitivity to noise, such as phonophobia, frequently accompanied by nausea or vomiting, which can be severe. Migraines can last from 3 to 72 hours and may become bilateral if not treated. Migraines are not fun, and the patient may be miserable by the time you see them. So let's talk about what we can do to help prevent migraines from occurring. So there's a lot of different non-pharmacologic treatments available, which I'm sure you'll talk about later in the program, but we're just here to talk about the drugs. So we're just going to talk about the drugs. There have been some newer drugs released recently in the past few years. The CGRPs, Nurtec, and then the serotonin 5-HT1F receptor agonists. But we're not going to go into a ton of detail about those. We'll just talk about kind of the typical treatments. So prophylactic therapy or preventative therapy will be taken every day. There's a number of different options. Beta blockers, Inderal is often used. Some anti-seizure drugs like valproate, tricyclic antidepressants like amitriptyline or nortriptyline, SNRIs. Some newer drugs that are monoclonal antibodies like Aimovig. Botox can actually be used. This helps by working with the neurotransmitters that carry pain signals to your brain. SNRIs can also be used. So there's a number of different options. So if the patient is having frequent migraines, we want to put them on preventative therapy. And then we also need to give them something for when the migraine actually occurs. So there are a few different options. Like I said, there are some newer options. We're going to kind of just talk about the older treatments that we have here, because triptans are still, pretty frequently used. So over-the-counter analgesics like Tylenol and NSAIDs are often used. There's a combo Excedrin, which is acetaminophen, aspirin, and caffeine. And this has all been shown to help for abortive therapy. There are triptans, which we'll talk about in a second. And then we have the ergotamines. They're not as used as much anymore. The triptans have really replaced ergotamines because triptans have been shown to be more efficacious. But ergotamine is a medication that's used for an acute migraine attack and can be used for cluster headaches. It is sometimes used in combination with caffeine. Ergotamine causes arterial constriction, resulting in decrease in migraine symptoms. Acute and chronic use can lead to ergotism, which is a serious toxicity from ergotamine. It can lead to ischemia secondary to constriction of peripheral arteries and arterioles. The extremities can become cold, pale, and numb. Muscle pain can develop, and gangrene can eventually result. If a patient is taking ergotamine and notices any changes such as pale, numbness, cold extremities, they need to stop taking it immediately. Triptans should not be taken with ergotamine. You need to wait 24 hours between taking the two, and ergotamine should not be used in pregnant patients. Antiemetics can also be used as needed to assist in abortive therapy. People who take, the reason we want to put patients on preventative medication is that people who take headache medication every day often develop medication overuse headache. So almost all of the medications used for abortive headache can cause medication overuse headache. There's a nice paragraph about this in our book, but this is why it's important to put our patient on a preventative therapy if they're taking their abortive therapy very often. And then let's talk about the triptans. So triptans are first-line drugs for terminating or aborting a migraine attack if the over-the-counter meds don't work. So obviously we don't want to put the patient on this if we don't have to, but if they've come to you and they've tried a number of different things and they're still not getting relief, then triptans are a great option. Sumatriptan was one of the first triptans. It can be taken by mouth, nasal inhalation, or sub-Q injection. It can also help with the nausea, neck pain, phonophobia that the patient experiences with the migraine headaches. There's not a ton of side effects that can occur with triptan use, but one of the major side effects of note is that it can cause coronary vasospasm. Some patients may experience chest symptoms such as heavy arms or chest pressure. These are usually transient and not dangerous. Triptan should be avoided in pregnancy, and triptan should not be administered to patients with coronary artery disease that currently have angina or uncontrolled hypertension. We talked about how St. John's wort and an SSRI taken together can lead to serotonin syndrome. SSRIs and triptans could potentially lead to serotonin syndrome as well. Again, triptans should not be taken with ergotamine, MAOIs, or SNRIs. Okay, and then moving right along to thyroid conditions. So let's talk about the thyroid. So the thyroid has a profound effect on metabolism, cardiac function, growth, promotes maturation in infancy and childhood, development. The thyroid stimulates energy use, stimulates heat, promotes growth and development. You can see it's obviously very important in our bodies. So when we're looking at medications for thyroid conditions, we want to look at what are our options. So what are the choices for thyroid hormone replacements? So we have levothyroxine, which is T4, or liothyronine, which is T3. Levothyroxine, or T4, is often used because it's stable and cheap and has a longer half-life. And when it's given, it's converted to T3 in circulation. So T3 seems like a better option to give, but when given, reaches high levels, and it's been associated with cardiotoxicity effects. This is because T3 is much more potent than T4. So there's some sensitization of catecholamines. So it's much better to give T4 or levothyroxine, which is much more stable and has less chance of toxicity. And it's also very hard to regulate and measure the levels of T3. So levothyroxine is the choice for hypothyroidism and myxedema coma. Some side effects to levothyroxine are hypothyroidism symptoms will be seen when given in excess. So increase in heart rate, nervousness, any of the hyperthyroid symptoms may be seen if too much levothyroxine is given, and then hypothyroidism if there's not enough. So if a patient is taking brand name Synthroid or levothyroxine 1 month, but then wants to take generic the next month, is this okay? And the answer is we should keep the patient on the same type of medication because it can vary the levels in their blood. So if they're taking generic, they should ideally stay on generic. If they're taking brand, they should stay on brand. Typically, levothyroxine is given orally. There are rare cases where it's given IV, such as myxedema coma. Few education points about levothyroxine. We have to educate our patients when they're taking it. It can interact with other medications. Levothyroxine should be taken 30 to 60 minutes before breakfast. Should be taken at the same way every day. Certain foods like grapefruit juice and foods containing soy can make levothyroxine less effective. Iron supplements, calcium supplements, antacids should be taken 4 hours before or after. Levothyroxine starting dose is typically 25 to 50 micrograms per day. We want to start, especially in the elderly, start at the lowest dose, or if the patient has a history of heart disease, because this can increase the risk for any sort of cardiac condition. So if a patient has a history of angina, acute MI, AFib, you want to go really slow so you don't cause any cardiac side effects. So you're going to increase the Synthroid dose by 25 micrograms every few weeks until the TSH is normalized. Typically in a normal adult, we base the dosing on weight, but really just depends on what's going on, how old they are, what other conditions they have. We'll recheck the TSH every 6 to 8 weeks until the TSH is normal. Of course, we want to tell the patient to, report if they have tremors, palpitations, nervousness. All can mean that the Synthroid dose is too high or the levothyroxine dose is too high. So then let's talk about hyperthyroidism. So what are the drugs that are used to inhibit the synthesis of the thyroid hormone? We have the prothiouracil or PTU and methimazole. So those are the two main drugs that are used for hyperthyroidism. These agents can be used long-term for hyperthyroidism or as short-term preparation before a subtotal thyroidectomy or radioactive iodine. So methimazole is typically preferred, we'll talk about it in a second, but methimazole is typically preferred except for women who are pregnant or breastfeeding or in a thyrotoxic crisis. So of note, methimazole prevents thyroid hormone synthesis, but it does not destroy existing stores of the thyroid hormone. So once therapy starts, it could take 3 to 12 weeks to produce a euthyroid state. There is, and this is a major note, a risk for agranulocytosis when taking methimazole and PTU. And there is a black box warning for severe hepatitis with PTU specifically. So again, PTU is more toxic than methimazole and requires more daily doses. So methimazole is preferred for most patients. There's 3 groups where PTU is preferred. A patient is experiencing thyroid storm if they can't tolerate methimazole, or pregnant women, but only in the first trimester, which we'll talk about in just a second. Beta blockers may also be used in hyperthyroidism to blunt the catecholamine effects like cardiac effects like tachycardia, restlessness, anxiety. Other treatments for hyperthyroidism are thyroidectomy, radioactive iodine, etc. Really they should only be used short term because of all these side effects and the black box warning. Okay, so let's talk about pregnancy and thyroid disease. So in hypothyroidism, levothyroxine will be continued. Pregnant women may need a larger dose due to the rapid rise in TBG levels resulting from the physiological rise in estrogen, increased placental transport and metabolism of maternal T4, and the increased volume of distribution of thyroid hormones. And then in Graves' disease, remember this because I'm sure you're going to see a question about it on your boards or somewhere. First trimester, you're going to use PTU. This is because in the first trimester, if methimazole is given, it can cause birth defects and it crosses the placenta. After the first trimester, methimazole should be started. This is because PTU can cause severe liver injury. There's that black box warning for severe hepatitis. So first trimester PTU, and then second and third trimester methimazole. And I think that's all I have for you today. So I appreciate you guys watching this, and please reach out if you have any questions. Have a great day.